Just to make my point regarding the disappearance of pelvic pain during the COVID, perhaps staying at home is a treatment, because patients that, usually don't want to go to work, and also working at home, it means that they don't have to be seated, and this is one reason of perhaps could be a reason of why they could be better during COVID as well. So, and I just want to renew my thankful on behalf of the Italian Urodynamic Society. It's been years that there is a partnership between our society and the Turkish Continence Society. Unfortunately, Tufan this year couldn't come in Florence, in my city where I'm working, because of quarantine. I'm really lucky and happy to be here, despite internet and the possibility to do my speech online. So these are my disclosures. What is the primary bladder neck obstruction? Is it an inappropriate and inadequate relaxation of the bladder neck during voiding? But which is the prevalence of the problem? Unfortunately, it's not clear. Why? Because data, it's limited to specific male patients. In this study, the prevalence was estimated about the 33-45% in young patients during the urodynamic study. The problem is that all the studies usually don't include patients over 50 because of the possibility of the influence of the benign prostate obstruction. And so it's quite clear that the prevalence of the problem it depends on the age. So if the age is lesser than 50, and there are severe lower urinary tract symptoms in about 1 out of 10 male patients, we should suspect a primary bladder neck obstruction. And although the presence of secondarism in the upper urinary tract are rare, and there are only some case reports about the presence of hydronephrosis in these patients, and the largest study included only 13 male patients. And the problem is that it's rare, but we don't know when the problem could onset, and also that perhaps it's underestimated, and we don't know actually which is the cause, since not all the patients show reflux during voiding. So the cause is not only the presence of high pressure during voiding. Regarding the etiology, there are several theories about changes on the bladder neck because of the onset of the occurrence of fibrosis, or some morphological abnormalities of the detrusor muscles in the trigonal area, as well as other theories involved some abnormalities of the neurological pathways, especially in the sympathetic nervous systems. But one interesting theory, very recent, is this one about postural problems. So gait abnormalities has been seen to be associated with an hypercontraction of the pelvis, and thus this could determine a bladder neck contraction and interfere with the normal voiding. And this theory, actually, it seems to be confirmed by other studies before about the correlation of musculoskeletal abnormalities in pelvic pain. And this is the problem. Who born before? Chicken or the egg? It's always the same thing. So we don't know actually if the contraction of the pelvic cause the abnormality of the gait, or if actually the theory could be right. But one thing, it's true. There is a significant association between pelvic pain and primary bladder neck obstruction in men, actually. The rate of pelvic pain in these patients is about half of the patient had pelvic pain together with storage and voiding symptoms. And the problem is that often these patients, at the beginning, the diagnosis is wrong as a prostatitis, as it was documented in this paper, and they usually had an average of 3 visits from urologists before the definitive diagnosis. And which is the gold standard for the diagnosis? It's video urodynamics, because the urodynamics alone is not enough. Why? Because for the definition of NITI, we need a radiological confirm of obstruction between the bladder neck and the distal urethra in the presence of a sustained detrusor contraction. So cystography plus urodynamic is the gold standard for the diagnosis of this pathology. Usually the mean flow max is under 15 milliliters per second, and instead the P-DAT during the flow max is estimated on average in the range between 20 and 70 centimeters of water. That's why sometimes the obstruction is not so severe, and we need radiography to understand the relaxation of the bladder neck during the voiding. And also, in the 50% of the cases, it's correlated with the presence of detrusor overactivity. That's why this patient have also storage symptoms in almost the 50% of cases. And according to NITI, there are 3 types of primary bladder neck obstruction. So one is the classic one, so it's an obstruction with high pressure and low flow. The second one could be an obstruction with normal pressure and a low flow voiding, but a narrowing of the bladder neck at the radiography. And the third one could be a delayed opening of the bladder neck during voiding. And what's about the treatment of these patients? Actually, there is a low evidence that alpha blockers can work. But of course, the first attempt should be this one. In these, all the reports about the alpha blockers use were only case series, and the success was good, even in the post-voiding residual, for amelioration of the Qmax, and also for the quality of life and EPSS score. But which is the problem with alpha blockers in these patients? Well, first of all, they are young, so they have to have this therapy for a long time. And one problem is the adherence of the treatment. And if we see this paper, the adherence after 2 years drops in about 50% of cases. Yeah, this one, okay? So you can see that the discontinuation of the treatment in patients under 50 years old it's about 80% of cases at 1-2 years. And another problem of these, so alpha blockers usually are stopped very quick in these patients, and the failure of in alpha blockers, it's a predictive factor for the diagnosis of primary bladder neck in these patients. In this study, it's documented that among 930 consecutive men over 45 years of age who were failure at 1 year of alpha blockers, they found that the primary bladder neck was found in about 37% of cases. So it was the second diagnosis after benign prostate hyperplasia, also in adult age. And it was depending also by the volume, the volume of the prostate. Another treatment option that it was proposed by an Italian group, it was botulinum toxin A in the bladder neck. We know that botulinum toxin A could be used for an injection of the sphincter, usually in the neurogenic patients with detrusor dyskinesia. But this is the only study in primary bladder neck obstruction. And the outcomes were very good at 9 months follow-up, and negative predictor factor for success, according to the authors, was an EPSS higher than 10 and a duration of symptoms higher than 5 years. But the gold standard is the bladder neck incision, of course. But which is the problem with the bladder neck incision in this patient? First of all, the ejaculation, the retrograde ejaculation, and even if there are some attempts using unilateral incision, even by laser, rather than using the classical electrocautery, and we know that unilateral versus bilateral could preserve, in more cases, the retrograde ejaculation. Also in unilateral, there is a difference in quality of the sperm. And in the long term, another problem is the redo surgery in these patients. And so we know that usually, despite the unilateral or bilateral incision, the rate of redo surgery is estimated to be about 20% after 3-4 years. Instead, this is, and in 10% of cases, this patient can have redo surgery even 4-5 times. And about the retrograde ejaculation, we know that in unilateral, the rate is about the 30% of cases that can have retrograde ejaculation despite this type of technique. And this is an interesting, very new technique proposed by an Italian engineer. They try to design a model and they at the end they saw that in spite to have an incision of the bladder neck, you can do some holes to not destroy the muscle fibers, and to have a greater lumen. And the lumen depends on the number of holes that you need to do in the ventral part of the bladder neck, which is the portion of the bladder neck in which there are more fibrotic tissue. And this technique could preserve the retrograde ejaculation. And it was done also in 6 patients with good results. So to conclude, we need to improve our knowledge about the etiology and prevalence of this problem. We need to consider this diagnosis in young patients with low volume of prostate, less than 30 grams, and when they do not respond to alpha blockers. Of course, we need more study to improve our evidence about treatment and the early prevention of the damage of the kidney and secondary of the kidney. Thank you.
Thank you very much, Mrs. Stefania. Bir veya iki soru alabiliriz. Buyurun hocam.
Ben sabahki konuşmacı Doktor Cruz'a ve Stefania'ya çok teşekkür ediyorum. Benim gibi biraz eskiler bunu bilecektir. Burada Fransız ürolog Marion'dan bahsetmek lazım. Çünkü bunu ilk defa 1800'lü ve sonra 1900'lü yıllarda onun sayesinde bu bilindi. Gençlerde gözüküyordu. Ben de kliniğimde, pratiğimde az olmayarak buna rastlıyorum. Hatta bu hastalar senelerce interstitial cystitis ve kronik prostatitis gibi boşuna tedavilerle vakit geçiriyor. Sabahleyin gayet güzel konuştu Cruz. Bunlar %80'lere varan, bir de aynı zamanda bunlarda tembel mesane de oluşuyor tabii. Böyle hastalara çok basit, eğer retrograd ejekülasyon sorunu yoksa hastalarda, böyle bir problem yok. Çünkü bu hastalar 50'li 55'li yaşlara kadar bilinmeden, tanı konulmadan gelebiliyor. Siz de bunları çok güzel anlattınız. Fakat bunlarda kesin çözüm gayet güzel anlattınız ki bir takım palyatif sözü tekrar girişim gerektiriyor. Bunlar da çok basit. Bizim asistanlığımızda basit bir mesane boynu açık rezeksiyonuyla eğer prostat büyümesi de başlamışsa simple prostatektomi ile kesin çözüme ulaşıyorlar. Bu konuyu gündeme getirdiğiniz için de ben çok teşekkür ediyorum.
Evet, Tufan hocamdan bir soru bekliyoruz.
Stefania, çok teşekkür ederiz. Harika bir lecture'dı hakikaten. Bu hastalığın etiyolojisi çok ilginç. Sen de bahsettin, sempatik sinir sisteminin bir aktivasyonu bunda suçlanıyor. Klinikte de benim gözlemim bu hastalar ve literatürde de bu aynı gözlemi paylaşan yazarlar var. Ve böyle gözlerinden öfke ve gerginlik fışkıran hastalar oluyor. Sanki böyle adrenalin fışkıran gözlerinden gergin tipler görüyoruz. Acaba bu artmış sempatik sinir sistem aktivasyonunun rolü olabilir mi? Bir de eminim literatürde rast gelmişindir. Bunu bir yürüyüş problemi, gait anomali olarak etiyolojisinde bazı yazarlar düşünmüşler. Özellikle kalça eklemlerinin asimetrisi nedeniyle pelvik tabanın hipertonisine bağlı olarak yıllar içinde gelişen bir internal uretral sfinkter hipertrofisi olduğunu düşünüyorlar. Senin fikrini alabilir miyim bu etiyolojiler hakkında?
Well, actually, we don't know the etiology. Otherwise, we resolve the problem, I think. Thanks for your observation. It's quite similar, for instance, if you think about also a patient with sacral problem, you know, they open the bladder neck, but it's not widely open. It's like fixed. You know, so it could be something similar to this kind of patient, a sacral lesion, but we don't know why this patient. Perhaps could be a peripheral damage of the nerve, a peripheral damage perhaps of the pudendal nerve, but there are no studies about the neurophysiological test in these patients, so we don't know.